as patients on the judicious use of antimicrobials. Now, in addition to today's talk, I also want to point out that you can follow PSV on either Facebook or Twitter, where you'll find daily postings of interesting antibiotic facts and trivia related to the celebration for Antibiotic Awareness Week. Now, for today's talk, I have nothing to disclose. So I have an interesting title, and I will defend this. So I do believe that any one of you listening today, you can become a pediatric antimicrobial steward from lessons learned from the Food Network. Now, I just want to get into some definitions. When I say antimicrobial steward, I need to explain what that means. You know, when I first heard that term, it was a really funny term. I didn't know what the heck that meant. So I just want to go into the definitions. So the word steward is a it comes from Old English. It's a very, very old word. So it literally means somebody who looks after a house. Now, some houses are bigger than other houses, right? Some people have castles. So in that sense, a steward was somebody who oversaw the day-to-day operations of a large property, okay? So throughout the centuries, the definition of stewardship, it has changed a little bit. So one commonly accepted meaning in today's age of steward is it's somebody who watches over other people. So it's in that sense, when I say the word antimicrobial steward, what I mean is it's a conservator of anti-infective agents who's going to ensure best patient care, okay? Now, in spite of events like US Antibiotic Awareness Week, in spite of growing efforts to do more and more antimicrobial stewardship interventions, we still have a long way to go here in the United States. So I just want to point out one study to kind of set the stage for us here. Okay, so this was published in Pediatrics. This was over a 10-year time period, so 2000 to 2010, and it looked at national prescribing trends for pediatric patients across the United States. In this 10-year period, they did see overall decrease in antimicrobial use, and that's exactly what we want to see. It's thanks to efforts such as this week. It's thanks to thoughtful physicians who act as antimicrobial stewards. They overall decreased the use of antibiotics in that 10-year time span. However, when you drill down, you look at very specific classes of antimicrobial agents. There was one outlier, okay, and that was the third generation of cephalosporins. So from 2000 to 2010, the use of ceftriaxone, cefdinir, and cefixime increased. And that was across all ages. That was a statistically significant increase. Okay, so this really, all kidding aside, it really broke my heart. Just as a reminder, I want to let people know, third generation cephalosporins, they are considered inappropriate for acute upper respiratory tract infections. When I say acute upper respiratory tract infections, what I mean is ear infections, sinusitis, and strep pyogenes pharyngitis. Now, to define inappropriate use, people have different meanings. For the sake of today's talk, this is what I mean when I say inappropriate antimicrobial use. So, okay, you're choosing something that has a higher cost. You're also more likely to select for resistant bacteria. You're also more likely to cause harm to the patients. Now, to delve into the cephalosporin expenditures and costs here in the United States, I want to cite a different study here. So what they did is they looked at expenditure from 2010 to 2015. And specifically, they drilled down just to cephalosporins. So this is all healthcare costs across the United States. And what we have here on the y-axis of this bar graph are hundreds of millions of dollars. Okay, so baseline data 2010, this is where we were. So $880 million spent in the United States just on the family of cephalosporins alone. Now, this increased in 2015. Again, we already talked about how use of cephalosporins had gone up. So by 2015, not surprisingly, there was higher expenditure on cephalosporins. So that went up to $1.1 billion, and that increase was statistically significant. Okay. Same research group, they did a really, really neat thing with their data, okay? They drilled down specifically to unique healthcare institutions to really see where was the expenditure, who was spending the most money on these cephalosporin agents, on these antimicrobial agents, okay? So across the horizontal axis here, okay, that is overall antibiotic expenditure by healthcare setting. And again, our units are hundreds of millions of dollars here, okay? So no surprise, pharmacies really took the cake. That was where most of the expenditure was happening. So in baseline data 2010, we're talking nearly $6 billion was spent in the United States pharmacies just on overall antibiotics. Okay, again, through stewardship interventions, through events such as this week, US Antibiotic Awareness Week, that number did go down. So in 2015, it dropped down to about $4 billion spent on antimicrobial agents in the United States. Okay. Now we drill down, we talk about hospital settings. Okay, similar pattern emerged here. Okay, so the overall expenditure in hospitals, approximately $3 billion in 2010. 2015, that went down to about $2.7 billion. Okay, so it's not the pharmacies, it's not the hospitals where they're consuming all these antibiotics and spending more and more and more. That's not what the data tells us. Okay, what we see here is actually outpatient clinics. Okay, so baseline data 2010, outpatient clinics spent $270 million on antimicrobials that they were administering to patients there in the office. This means they're giving injectable antibiotics such as ceftriaxone. Okay. In 2015, that number increased. It didn't increase by a little bit, it increased by a lot. So we're talking from $270 million to about $700 million. That's an increase of over about 150%, and that was statistically significant. Now, talking about something slightly different, talking about selection for resistant organisms because of inappropriate antimicrobial use. We're talking about a different study here. So just to give a quick definition here. So when I say the term Enterobactericeae, what I mean is a family of gram-negative organisms that includes E. coli, it includes Klebsiella, it includes other organisms. Common things that can cause UTIs and other infections, okay? So what this research group did is from 1999 to 2011, they collected data on these isolates throughout children in the United States, and they noted the frequency. How many of these were resistant to third-generation cephalosporins? So as a reminder, these gram-negative infections, they pick up resistance to so many different antibiotics so rapidly. So we're gonna talk about what happens as the amount of third-generation cephalosporins increase in the United States. Let's follow that resistance pattern across the same time here. Okay, so on the y-axis here, just to orient you folks, what I have are number of isolates per day, so per calendar day, 365 days. This is a number that we would see per day. On the horizontal axis here, we have each year of the study period. Okay, so this is what we found. So we started off in about 1999 at about 14 cases a day of Enterobactericeae specifically resistant to third-generation cephalosporins. Unfortunately, as use of the third-generation cephalosporins increased, so too did the resistance of these gram-negative organisms. So by the conclusion of the study, 2011, what we saw was more than a doubling. So we went from 14 cases a day to 30 cases a day. Unfortunately, that was statistically significant. And I just want to talk about a different study when we talk about the harm that third-generation cephalosporins can have on patients. Okay, so this was an outpatient setting. There was about 2,400 encounters, specifically related to upper respiratory tract infections. So again, ear infections, sinusitis, strep pyogenes pharyngitis. And these researchers broke down the groups that they were looking at into one of two cohorts. So one cohort was narrow spectrum therapy, and they defined narrow spectrum as penicillin or amoxicillin for these infections. Okay. The second cohort was broad spectrum therapy that included anything that wasn't penicillin or amoxicillin. So augmentin, any of the cephalosporins, any of the macrolides. Okay. And what they did is they followed these patients based on their treatment forward in time. So one of the outcomes that they followed was symptoms at day 3. So they were taking antibiotics at day 3, and these researchers called the families. They asked, how is your child doing? Okay, so what we have here are the outcomes of that. So narrow spectrum, you can see 38% of the patients still had symptoms present at day 3 versus broad spectrum therapy, 41% of those patients still had symptoms at day 3. Okay. When they did matched analysis between these two cohorts, okay, there was no statistical difference between the two of them. Okay. However, they did see a difference when it came to adverse effects. Okay, so antibiotics causing harm to the patients. This included a wide range of symptoms. Okay, it could involve rash, diarrhea, candidiasis. Okay. For those that received a narrow spectrum agent, 25% of those patients ended up having an adverse event versus 36% of patients who took a broad spectrum agent. Okay, when they did matched analysis, unfortunately, they did see this was a statistically significant increase. Okay, so just to stop and think about that for a second, what that means is therapeutic benefit, you don't see that when you use a broad spectrum agent versus a narrow spectrum agent for any of these upper respiratory tract infections. Instead, what you're doing is you are causing direct harm to patients. You are giving them a side effect because of a broad spectrum agent when a narrow spectrum agent would have just done the job just as well. Okay, So I just want to pause there. You know, if you guys are internalizing this data, I know some people are thinking like, well, it's not me. I'm not the one that's prescribing these third generation cephalosporins. It's the urgent cares. It's the clinic down the street from mine. They're the ones that are doing this. So I just want to pivot from there and go off on a little bit of a side tangent here. I want to talk about this phenomenon called tragedy of the commons. Okay. For those of you that know what this is, primarily it's used in this day and age related to economics. Believe it or not, it actually has its roots in biology. So it was first proposed in 1968 by a biology professor, Dr. Garrett Hardin. He was specifically talking about population control, but he might as well have been talking about antibiotics because it really, the same principles really apply here. So just define what I mean when I say tragedy of the commons, okay? So in a setting where there's freedom for all individuals to use a shared resource to the maximum extent possible, it's inevitable. You will exhaust that resource and you're going to result in what Hardin referred to as ruin to all. Okay. So graphically, I want to show you what that means. So let's just say hypothetically for a second, we have this open pasture. Okay. Nobody owns the land. People can come and go as they please. Nobody's going to be upset about that. So one day, a farmer is forward thinking. He's like, well, if nobody's using that to feed a cow, why not take my cow there? So it doesn't cost him anything. His cow gets fat, he can take it to market. And somebody else sees this, they do the same thing. And another person does this. And now we have a fourth person who does this. Unfortunately, for this stretch of land, 4 cows was too much. Okay, they ate up all the grass. Now the pasture is completely ruined. Okay. Slowly but surely, okay, all the farmers that were involved, they realized we overdid it. You know, we had too many people using this resource, we overdid it. Okay? That's what I mean when I say tragedy of the commons. Okay? Just compare and contrast that scenario to what you guys see on the right hand of the screen here. Okay? So this is a different scenario where there's a pasture, but it's not open access. Okay? This is a single owner of the pasture. They have accountability, okay? They have responsibility. They want to be a steward. They want to conserve this precious resource, okay? So they know, if I have 4 cows on this piece of land, that's too much. They're going to eat too much of the grass. The pasture is going to be ruined, okay? But if I limit that to just 3 cows, that's good enough, okay? The cows have more than enough to eat. It's not going to overtax the land, okay? So that's really the model that we need to follow. So to ensure that we have antimicrobials to use for future pediatric patients, all of us, we have to act as pediatric antimicrobial stewards at this moment in time. Okay. Now, I know what some of you are thinking, you know, I didn't get training on this. I have no idea still what antimicrobial stewardship means. So I just want to reframe your thinking with that. Okay, so as a healthcare provider to children, you already have the tools, you already have the spirit to become an antimicrobial steward. I will argue antimicrobial stewardship is no different than anything else that you folks do day in and day out. This is no different than anticipatory guidance. This is no different than giving vaccinations. This is all about preserving and maintaining the health of children and delivering excellent pediatric care. So from there, I just want to take a second and talk and introduce something else here. So for today's talk, I really want to throw down a challenge to the listeners, okay? I really believe anybody can become an antimicrobial steward and not use 3rd-generation cephalosporins for acute upper respiratory tract infections in children. So again, ear infections, strep pyogenes, pharyngitis, sinusitis, okay? Don't use ceftriaxone, don't use cefdinir, don't use cefixime. Now, there's many, many ways that we can accomplish that, and I really want to highlight key things that people should, key steps people should take to become an antimicrobial steward. So in my mind, I've simplified this, okay? I think there's really 2 paths to becoming an antimicrobial steward, okay? So there are CDC-endorsed elements. In addition to that, I think there's also these things that I call adjunctive elements, okay? So at some moment in time, it might seem like these are 2 paths that are parallel to one another. I would argue at some point, though, they are going to intersect. They're all going to lead to the same path to success to becoming an antimicrobial steward. Okay? So we're going to go through, we're going to define what I mean by each of these. So for the CDC endorsed elements, okay, for you guys to know, this is available on the CDC website. So there's a specific document that people can download. It talks about key things that you need to have in place in your office to successfully carry out antimicrobial stewardship in the clinic setting. Okay? I'm going to really make things simple for you guys. I'm going to paraphrase 4 key things. You absolutely have to have these 4 key things to introduce antimicrobial stewardship into your practice. Okay? So starting off at the top, there has to be institutional dedication and accountability towards responsible antimicrobial use. Everybody has to get inspired. Everybody has to agree to this, okay? Second thing, you have to implement a policy. Pick something and be willing to stick with it, be willing to modify it as needed, okay? Third element, you have to be able to track and report on provider antimicrobial prescribing. Okay, this is like quality improvement here, right? You have to be able to see what you're doing, see if it's making any difference, okay? And the last element is education, okay? So that's seeking education from an expert such as me. So I deal with infections, I deal with antimicrobial prescribing, seeking expertise from people like me, but also in turn, imparting that education on the patients, on the families, okay? Now, like I said, there's adjunctive elements, so I'm going to explain what I mean when I say adjunctive elements. I did take inspiration from a very unconventional source, and I'm gonna make the argument of how we can take elements from the Food Network and apply them to antimicrobial stewardship. So I do admit, I like cooking, I like baking, I do watch a lot of the Food Network, and one of my guilty pleasures is a show on the Food Network called Restaurant Impossible, okay? So it's hosted by Chef Robert Irvine. That's the gentleman that's pictured there. And for those of you that are not familiar with the premise of the show, let me just quickly explain what that means. Okay, so it's a very simple premise. So in one episode, Robert Irvine is invited to take his crew to a failing restaurant business. Okay, this is a business that will close if something doesn't change. And it's called Impossible because he has a set of criteria. So he has $10,000 to make renovations and repairs to the restaurant setting itself, but he only has 48 hours to invoke all of these changes. In addition to doing a physical restoration of the restaurant, he also has to inspire staff. He also has to revamp the menu. But I would argue the most important thing he has to do is he has to talk to the owners of these restaurants. He has to get them to acknowledge that what they're doing is not working and they have to fix their flaws. That's all to turn things around to make them into a successful business, okay? Now, like I said, I've watched a lot of episodes of Restaurant Impossible, and I think the episodes tend to follow a formula, but because this is the Food Network, I'm going to say they tend to follow a recipe, okay? So I do think he tends to follow the same steps to ensure a successful transformation for these businesses, for these owners, right? There's a failing business, he's attempting to turn them around into something successful. So first thing that Robert Irvine's going to do, he's going to come in, he's going to leverage expertise, okay? Meaning that he comes in, he's a successful restaurateur. He has helped so many other restaurants before other people, okay? He is coming in as an outside expert, trying to see what works, what doesn't work, okay? So again, listening to somebody like me talk about antibiotics today, this is exactly what we're talking about, okay? Second element that he does is if he's going to make changes, it's going to be very simple changes, okay? Nothing complex, has to be simple, okay? Third thing he's going to do, he's going to tweak the environment. So part of this is physical restoration of the restaurant itself. Part of this is just changing the work environment. I cannot tell you how many times in these episodes, it's absolutely ridiculous how people are just taking an order. It's so hard to take an order from the table and then transmit that order to the kitchen and then get the food delivered to the correct table. So making small changes to enhance the experience, it's all about promoting good habits, ensuring success after he leaves. All right. Now, I know I've thrown a lot of information at you folks. Okay, again, there's the CDC elements. There's what I call the Restaurant Impossible elements. And how can we possibly combine all these things together to create antimicrobial stewardship program in your office? Okay, so I'm not asking you folks to reinvent the wheel. Okay, rather, all we have to do is follow the success of other pediatric clinics. Okay, people have published what they've done. They've set models that other people can easily adapt, easily follow. So one great example of successful outpatient pediatric stewardship comes to our neighbors from the north, so just in Pennsylvania. Okay, so I'm going to break down and talk about what they did. So 18 pediatric clinics serving children in Pennsylvania, they were randomized. Okay, 9 clinics were put into a study just where there was education only, meant to decrease prescribing of broad spectrum antimicrobial agents for upper respiratory tract infections. Okay. Second cohort received more intense intervention. In addition to that one-time teaching, they also had report cards generated on a quarterly basis, meaning that the prescribing data was put into a database, and each provider was given a report card to see, well, how did I do relative to my peers during the same time period? Additionally, the research team gave personalized feedback to each provider in terms of what they could do better as the study period went on. So they followed these people for a year, and this is what they found. So in the first cohort, those that just got one-time teaching, okay, they actually did see success. They actually did decrease broad spectrum prescribing for upper respiratory tract infections. So baseline of 28%. At 1 year after they went through this teaching intervention, okay, that decreased to 23%. That's not too bad, okay? They saw incredible success with the intensive intervention group, okay? So in addition to the one-time teaching, they got quarterly report cards on the antibiotic prescribing. They also got individualized feedback from the research team. So what they saw is broad spectrum prescribing for the upper respiratory tract infections. It went from 27% down to 14%. They cut their prescribing in half, okay? Very simple intervention. This was statistically significant. So again, these folks have set a model that other people can follow for successful outpatient antimicrobial stewardship. Okay, so I just want to reflect on this study that we talked about from Pennsylvania just for a second. So what I've put back on the screen here, these are the 4 core elements of the CDC recommends for successful outpatient antimicrobial stewardship. Okay, so just break down, talk about what elements, what things did this study hit, okay? So I would say they definitely hit the first 2. Okay? So the groups that agreed to participate in the study, they showed accountability. They wanted to have responsible antimicrobial use. That's why they agreed to do the study. Okay? They also put into place a policy. They made a decision as a group. Yeah, let's cut down on inappropriate antimicrobial prescribing for these specific conditions. Okay? As we talked about, the cohort that got the intensive intervention, those that got the report card, they got personalized feedback, okay, they had that reporting in place, okay, and that was really just there to sort of like a carrot to help people along throughout the study. And they also received education, right? So they got knowledge in terms of why they should use something over another. Okay, so no surprise, they hit all 4 elements. That's why it was such a great success. All right, so just to reflect again, so let's invoke what I call the restaurant impossible elements. Okay, so going back to this Pennsylvania study, which of these elements did they hit? Well, I would say they definitely leveraged expertise, right? You know, this research group, they were invited in, they gave education for the more intense cohort. They also gave periodic reviews, personalized feedback for prescribing practices. Okay, so they used the expertise that they had. Okay, I would argue they also made a very simple change. This was a very, very low cost intervention that was done, right? Just was physicians' time. That was it, right? It's not like I'm asking them to do these elaborate things in the computer, have these elaborate charts to go through. It's just very simple things. Okay? So again, you can use these two pathways and join them together to have success with pediatric outpatient stewardship. All right, so I want to talk about another intervention, which is also very simple, also very powerful. Okay, and that's basically making what I call the poster pledge. Okay, so basically on a giant poster, it's very easy for people to see. You make a statement, basically says, I guarantee that I will only use antibiotics when they are necessary, okay? And you're gonna also put your money where your mouth is with this statement. You're gonna have your own photo, you're gonna have your signature there, okay? That's in plain display for everybody to see. We're gonna talk about a study that shows the power of such a simple thing, okay? So clinics in Los Angeles, they were randomized, okay? They either had a group of physicians who had no poster, they had none of this displayed, they just kept prescribing, seeing patients like they normally would, versus a group of physicians during the same time that they had these poster pledges in place in their exam rooms. Okay, and they compared to see what the prescribing patterns were. Okay. So specifically, these researchers looked at outcomes with upper respiratory tract infections. So all the same stuff that we've been talking about up to this point. I will let you guys know this was not specific to pediatrics. This was adult medicine. Okay. So you can see the breakdown there. So the number of of encounters where there was no poster versus the number of encounters where there was this antibiotic pledge posted, okay? So for those that did not have a poster, so during this intervention period, during the study period, the researchers actually saw that the amount of antimicrobial prescribing went up by 10% from baseline, okay? So, all right. So what about the intervention group, right? The ones that had the posters printed. So shockingly enough, same duration, okay, they're seeing patients at the same time of year, prescribing went down by 20%. Okay, and that's the only difference between these two groups was that poster being present. Okay, so statistically, that was significant. Okay, again, simple intervention, so powerful. So again, let's reflect on this study using the poster pledge. So CDC elements, which of these did it hit? So definitely show dedication, accountability. That's plain and clear up front for everybody to see there. Okay. They also implemented a policy. Okay. We believe in judicious antibiotic use. There's my name, there's my signature. Now, again, to go to the adjunctive elements, so the restaurant impossible elements, so which of these did the posterior intervention, which of those did it hit? So that's, again, it's a very simple change. What they did is they also tweaked the environment, right? Like this is very low cost. And it's not like I'm asking them to have, again, a sophisticated computer system, pull out charts and charts and charts. It's something just sitting there in the exam room for patients to see. Okay, so again, I'm going to take a pause here. So again, some people, you're like, well, that's all well and good. I see the power of these interventions. I still don't think that I can make a change from prescribing certain antimicrobial agents for various reasons. So I just want to acknowledge some of that and go through, certain, I want to do some countering for some of the thoughts that people might have. Okay, so I would say, why you would reach for inappropriate antimicrobial agent, there's multiple factors. Okay, some of them we can control, some of them we cannot control. So I would say, I will acknowledge, sometimes people reach for third generation cephalosporins, not because they just don't know any better. It's just because there's, supposed antibiotic allergy. Like, well, they had some reaction to penicillin or amoxicillin. I feel like those are off limits, so I wanted to use something else instead. Okay, so that's one reason. I totally acknowledge that. Another reason is diagnostic uncertainty, right? Like you're just not certain. Like, well, I know they have a fever. I don't know why they have a fever, okay? I know they have an ear infection. I don't know if it's a viral infection. I don't know if it's a bacterial infection, okay? So people tend to err on the side of caution, treat for a bacterial infection, given diagnostic uncertainty. Okay? Another element that I totally acknowledge is time constraints, right? Like you guys have such a limited amount of time to see these patients, right? 10, 15 minutes for a sick visit. We try and shoehorn, no matter what the chief complaint is, you try and shoehorn them into the same 10, 15-minute time span, right? As you guys know, sometimes it's just easier to write the antibiotic prescription than explain to the family why they don't deserve an antibiotic. Okay? And then lastly, again, I totally acknowledge this. Okay, there's the concern the family is going to be unhappy with you, or there's the concern the family came in, they're expecting an antibiotic, and you hate to disappoint them. Okay, so we're gonna address all these elements now. Okay. So in terms of the antimicrobial allergy, so specifically penicillin allergies, okay, it's widely regarded that about 10% of patients will get diagnosed with a penicillin allergy. Okay, when I say allergy, it's very hard for us to truly diagnose if the reaction was truly involving immune system reaction or not. We see something with our own eyes. Phenotypically, we're not necessarily doing the direct allergy testing, the immune system inquiry, to see if it really was a true reaction or not. The good news is, though, a lot of these patients that get labeled with penicillin allergy, most of them, truthfully, they have a non-severe reaction that's not going to recur each and every time that you challenge them with penicillin or amoxicillin. Okay? So there is this growing body of literature that supports delabeling penicillin allergies, challenging these patients with amoxicillin, with penicillin. If they tolerate that, take away that allergy. Okay? And a lot of the reactions that people are having, it's just not something that's going to stick with them later in life. So to that effect, I just want to remind people, okay, Dr. Leverson did talk about this at ZIE conference the other year, but just to remind folks, okay, in a situation where there is a low risk reaction, okay, that means vomiting, that includes rash, that also includes urticaria, okay, you can still safely challenge that patient with oral amoxicillin, and you don't have to even do this in the hospital. You don't have to do this in the emergency department, the allergist office. You can do this in your own office. Of course, I would ask you guys, please ensure you have Benadryl on hand. Please ensure you have epinephrine on hand in the rare chance this patient actually does have anaphylaxis to the challenge. Again, most patients, non-severe reactions, chances are they're going to do just fine. So every now and then, I do recommend doing this on patients at the hospital. I've never seen anybody have a reaction from an amoxicillin challenge in the hospital, okay? Just last week, I also had a patient of mine that he was labeled with a penicillin allergy for having a rash. This is a 19-year-old that I saw. At 9 months of age, he had a rash with penicillin, and that just stuck with him for the rest of his life. And he comes to see me because he has a skin and soft tissue infection along the mandible. And I really want to give him a good antibiotic that would cover MSSA, would cover strep pyogenes. So that would be Augmentin, that would be Keflex. And that penicillin allergy really put a damper in that. So I had a discussion with the family, patient and his mother. They agreed, let's do the challenge. He tolerated Keflex. I'm so happy to say he got better on Keflex. He was not getting better on clindamycin. That's why I wanted to change him to something else. He got better on Keflex. So I'm so glad that I could do that for him. All right, so going into the other elements, again, diagnostic uncertainty, time constraints, and then the patient satisfaction. So again, we're going to talk about things that you guys can do to completely erode any of those concerns. Okay, so one thing I want to talk about, again, it's the same thing we just talked about, right? It's having that antibiotic pledge on display for patients to see. It's also being willing to reevaluate the patient, okay? Don't feel like there's this pressure. I have to fix them now or I'm gonna miss the opportunity, okay? Don't be afraid to reevaluate. The last thing I wanna talk about is using enhanced communication skills. I'm gonna explain what that is in more detail in a second here, okay? Going back to that antibiotic poster, that signed pledge, again, you have to have your statement, you have to have your picture, you have to have your signature there, okay? This completely reframes the patient expectations. Again, this has been studied and widely adopted across the nation since that study that we talked about came out, okay? This is such a simple passive intervention, but it really, again, the patient is looking at this in the exam room. They haven't even talked to the physician. You guys haven't even opened your mouth yet. They're just reading this, and it's showing that you really do care for patient safety, and it's reframing their expectation. Well, so maybe if the doctor says, I don't need an antibiotic, I'm not going to get an antibiotic, and I'm okay with that. Okay, so going to the other aspects, so reevaluating the patient, I just want to point out your attention to this Cochrane review from 2017. Okay, so looked at what happened when there was delayed prescribing for various infections. I'm just going to drill down, look at outcomes related to delayed prescribing for ear infections and pharyngitis. Okay, so no surprise, okay, patients that had ear infections, that had pharyngitis, their symptoms took longer to resolve if there was a delay in antimicrobial prescribing, right? So they didn't get it at the exact time of the physician evaluation. They got it maybe a couple of days after that evaluation because they called the doctor back and said, I'm not feeling any better. If anything, I might feel a little bit worse. Okay, so at that point, okay, you've reached the threshold for me where I want to prescribe antibiotics, okay? Now, what's interesting about the delayed prescribing, again, people have concerns like, well, I just don't want anything bad to happen to the patient. So again, in this review for patients that got delayed prescribing, okay, none of them had an increase in infectious complications. So it's not like patients that took a couple of days to get started on antibiotics. It's not like all of them are going to the hospital super sick, okay? You have time to make the correct diagnosis, okay? The other thing I want to highlight from this study is that delayed prescribing, it did not decrease patient satisfaction. Again, really rethink, how the patient might be approaching the sick visit encounter. They don't necessarily expect to get an antibiotic all the time. So I just want people to be aware of that. Okay. And then lastly, we're going to talk about enhanced communication skills. Okay. So again, it's a 4-part strategy. We're going to go through each element of the strategy. Okay. This is something very simple that you can do in the office. Okay. It really, as you get practice, you get adept at doing this, it's really going to become very natural. My guess is a lot of you folks, you already do some of these elements, if not all of these elements, as you see patients day in and day out. Okay, so what I mean when I say enhanced communication skills, okay, so very plain and simple. State your exam findings out loud for the family. Okay, no ambiguity. This is what I see, this is what I don't see. Okay. Next step in the enhanced communication skills, you want to give them a clear diagnosis. Okay, so your rapid strep test is negative. I don't see clear signs of infection in the pharynx. This cannot be strep pyogenes pharyngitis. Okay. Third step, you want to give an explanation why antimicrobials are not going to be given, but at the same time, you also need to give them what's called a positive treatment. Okay, so you're not prescribing antibiotics. However, I want you to try something else to relieve your symptoms. Take Motrin for relief of your pain or fever. Okay, elevate the head of the bed to relieve coughing at nighttime. Give honey to your child to relieve cough if it's age appropriate. Okay, do something else. I'm not saying do nothing, like no antibiotics and leave. I'm not saying do that. I'm saying give them something else to help relieve the symptoms. Okay. And the last element of enhanced communication is present a contingency plan. Okay, if you're not better in 3 days, call my office, let me know. We'll talk again if I need to do something different. Okay, so if you really stop and think about this, again, my guess is people do this naturally all the time. I have to admit, I do this all the time myself too. I mean, the easy example I can think of is when I get referrals when there's a concern for Lyme disease. Okay, so I literally do this. I will examine the patient. I will state out loud to the family. So I do not see a rash that's consistent with erythema migrans. You're not giving me that history. I do not see signs of arthritis. And the Lyme testing that you have, that is negative. Okay, so then I give clear diagnosis. This cannot be Lyme disease. Okay, maybe it's a viral infection. Maybe it's autoimmune disease. Okay, then I'm going to tell them why I'm not going to give antimicrobials. Instead, I'm going to, in addition to that, I'm going to tell them, well, let's do something else instead. Take Motrin for your pain. Okay, let's get some laboratory testing to get some more information to figure out what's going on with all this. Okay, and then lastly, there's that contingency plan. Okay? If you're not feeling better in a week, call my office, let me know. Okay, I can take another look at you. We can figure out if there's something else that just wasn't apparent at the time that I saw you first. Okay. All right, so I just want to show you guys the power of enhanced communication. So in state of Washington, okay, about 1,200 pediatric outpatient encounters specifically for upper respiratory tract infections. A research group came in and they conducted surveys on families as soon as the physician visit was concluded. Okay, so they asked to rank the physician on a scale of 0 to 10. How would you rank the physician, and give elements, what did you like about how the physician handled the encounter? Okay. So this is what they found. So they looked at, one of the outcomes they looked at was, well, what was a predictor for a physician achieving the highest rating? So a 10 out of 10 ranking, okay? So again, much to people's surprise, it was not giving an antibiotic, okay? People need to really reframe their thinking. It's not that families are necessarily walking into this sick visit expecting to get an antibiotic. Okay? Statistically, giving an antibiotic did not give you the highest physician ranking. Okay? Do you want to know what gave you the highest physician ranking? It was the use of enhanced communication skills. Okay, so it's explaining things out loud, giving a clear diagnosis, stating why an antimicrobial agent was not going to be given, but also rendering a positive treatment. Okay, take Motrin for your pain, relieve, elevate the head of the bed at nighttime to relieve the coughing. Okay, statistically, that was the best predictor for physicians getting the highest ranking. Right, so think about that. Not giving an antibiotic gave you the highest ranking in this study. Pretty cool. All right, so we're wrapping things up here. I just want to leave you folks with some closing thoughts. So again, third generation cephalosporins, they really are inappropriate for acute upper respiratory tract infections in children. Okay, I don't want people to be using them. Okay? Now, in terms of becoming an antimicrobial steward, okay, there's a lot of resources you guys can use. My suggestion is just to tap a few of them. Okay, definitely follow the CDC stewardship elements, and that includes having accountability amongst your organization, implementing a very simple policy, tracking your antimicrobial use over time, and also seeking out education. So listening to experts such as myself, and also providing that education to the families, to the patients that you're seeing. Okay. Adjunctive therapies that you can adopt. Okay, I would say it's what I call, again, the restaurant impossible elements, right? So leverage expertise, again, listening to somebody like me, seeking out others to, read their studies, read their success stories, okay? Also, just putting in a simple plan. Again, the things that we've talked about, not complex. Anybody can do these, okay? And then the last part of the restaurant impossible elements, tweak your environment. Do something to promote good habits that people are going to sustain in the long run. So again, that poster pledge, perfect example of tweaking your environment. Something very, very simple, but it's very, very durable. Okay? Then other adjunctive strategies, antibiotic allergies. Okay, low risk allergies, including urticaria. Very unlikely they're going to have a bad reaction. Okay? Give them oral amoxicillin in your office. See if they tolerate that. You can take away that supposed penicillin allergy. Okay? And the last adjunctive strategy that we talked about, use those enhanced communication skills. Okay? Again, that does not take that long. As you are examining the patient, you're basically saying these things out loud. So it's not like you're sitting down, you're having this half-hour discussion, right? You're just clearly coming to the conclusion, this is what I see, this is what I don't see, this is what I want to do for it, this is why we're not giving an antibiotic. If anything is different, if anything is worse, please let me know. Please come back. We can always take another look. Okay? So in conclusion, I just want to remind everybody, I truly believe anybody can turn into an antimicrobial steward. Okay? And with that, I just want to leave folks with a closing thought. So again, I really want people, meet my challenge. Okay? Don't use third generation cephalosporins for acute upper respiratory tract infections in children. Okay? So that's my concluding slide. I'm happy to take questions. Let me just unshare my screen here.
Any questions? Remember, you'll have to unmute yourself. You may have covered it all.
So I will say, my group is stretched a little bit thin with the pandemic. But like I said, this really is a topic that's near and dear to my heart. I really do believe in antimicrobial stewardship. At any point, I would encourage you folks, don't hesitate, reach out to us. I'm always happy to talk about how we can implement the elements that we just talked about in today's talk into your particular practice.
Okay, and with that, we'll just say everybody have a great weekend, and thank you. Oh, wait, hold on. We have a question. Is amoxicillin once daily appropriate for strep pharyngitis?
Yeah, so good question. So yes, you have many dosing options when it comes to treating strep pyogenes pharyngitis for amoxicillin. So the traditional route that most people learn is you give amoxicillin twice a day. Now, you actually can, so whoever asking this question, they're right. Like, you can safely give amoxicillin once a day and still have therapeutic effect against strep pyogenes pharyngitis. And if you don't believe me, look at the red book, it's there.
Okay, what would you recommend for refractory OM?
Yeah, so always a tough one. This is assuming you've kind of gone through that escalation. So hopefully you started with amoxicillin and then you escalate to Augmentin, still not getting better. And then the question is, well, what the heck is, what's the next thing that I reach for at that point? Honestly, as I've told people in the past, if you're not cutting with Augmentin, typically that means it's not going to be strep pneumoniae. So again, strep pneumoniae, common cause of ear infections, it's considered extremely susceptible to either amoxicillin or Augmentin. So that's not going to be the issue if you're not seeing clinical improvement. Chances are it's probably going to be a gram-negative that's causing the infection at that point. You're really rolling the dice. What I would say is if it's a recurrent infection or something that's significantly worsening, chances are they're going to need to see ear, nose, and throat doctor. At some point, they might just need to have a tympanocentesis done. That might be therapeutic, so it's going to relieve their symptoms. It also can be diagnostic too. You can take a culture, you can either confirm or refute the suspicion. This was gram-negative, that was highly resistant, that's why the patient wasn't getting better. Or, this is strep pneumonia all along for some reason, whether the patient was not taking the appropriate amount of antibiotic, they weren't compliant with the prescription, something else was causing the treatment failure. So it's tough. Obviously, if they have frank mastoiditis, if they have suppurative complications, that's something where you're going to escalate to the hospital. So maybe not necessarily manage that in outpatient setting, but if it's just somebody, they have the persistent infection, I'd say, see what happens. Let them go to see ear, nose, and throat doctor, get it to tympanocentesis, get more information.
Any other questions?
All right. Well, thanks again. Thank you so much for joining me with today. I'm very excited to share all the things that we talked about. So thank you so much for listening.
Thank you. Everybody have a great weekend.
Thank you.
People are saying thank you in the chat. Thanks, Dr. Nuibe.
Thank you.